So this is kind of a discussion about our response to inpatient airways at our hospital, as well as kind of the program itself and the history of that. So it was about, how many years ago now that?
4 or 5. Probably.
4 or 5. We took over from anesthesia so they could focus more on their operating room cases. But it all depends. A lot of hospitals, anesthesia does this. Sometimes anesthesia does it, or overnight the ED physician does it. The ICU sometimes responds. So I think there's a lot of different variations, but we wanted to just talk about our success at our program. And I think it's been overall really good to respond to the inpatient emergencies, as well as kind of increase the collegiality with our inpatient colleagues as well. I don't know what your thoughts on it were.
Yeah, I mean, I agree. I think the benefits of having an ED faculty respond to every medical emergency 24/7 is that they can almost respond in like a all hazards fashion, in that our primary responsibility is airway management. And so we assess the airway, decide what interventions are needed and perform those. But then we can also be called upon if they need another emergency procedure or advice about resuscitation, or these kind of things we can add in those few minutes we're there as well.
So just to overview our program a little bit, there's ED faculty that's responsible for responding to inpatient emergencies, and that is anywhere inpatient in the hospital, including the ICU. Our ICU faculty do perform airway management as well, but if they're for some reason not available, if it's off hours or it's a difficult airway, we might be called up there. So primarily we're going to the inpatient floor, as well as in the SICU, where we're called to intubate as well. We'll have your variety of airways with halos and C-spine immobilization and stuff. So we've got, at very minimum, with the overnight shift, we've got 2 faculty available in the department. I think a typical argument here for people is, why would you pull an emergency physician out of the department for 15, 30, 45 minutes if it's a really difficult airway? What are your thoughts on that?
Yeah, I mean, I think that's the downside to this, is that our primary job is to take care of emergency department patients and keep patient flow going and triage and resuscitate. For the last 15 or more years, we've never had a shift that's solo coverage in our busy urban level 1 center. So even at night, there's double coverage. And so, we think pros, cons, we can spare that faculty member to go up and respond to a medical emergency. And I think it's worked well. I think our ED, as we've talked about on this channel, intubates a lot, 1,200 cases or more a year. We're a teaching institution, so our senior residents get lots of experience at managing all types of airways. And as faculty, we supervise those procedures, but we rarely get our hands on the laryngoscope because the residents have had such a high success rate. And so this is a great opportunity for all of our faculty to feel that pressure and maintain their skills with tracheal intubation and supraglottic airway use, cricothyrotomy, these things that have come up on our response to medical emergencies.
Yeah, I think you wouldn't think that you'd get so much, but I mean, how many do we do in an average year? How many will we do?
Yeah, we've got data on about 140 responses, and the data we're collecting is still unpublished, but we'll get it out there to share with the field soon. We send a research assistant with a data collection form to each of these medical emergencies so they can be an independent observer and give us a really objective view on procedures that were performed and the outcomes.
Just like we do in the state room.
Because I think this is a key thing in that whether if you're instituting a new airway management program pre-hospital like you have with our critical care paramedics, or something new in the ED or in the hospital, it's your responsibility to track the data and be able to report your quality outcomes to anyone that wants to know. It helps you with real-time adjustments in your practice too. So we collect that data, and what we found in about 140 responses is that about 6 out of 10 responses are intubated. So 40% were responding and are called away or called off because other strategies are used. Intubating about 60% of the time. And we've tracked first attempt success, where we really define that strictly as 1 insertion of a laryngoscope blade, 1 bougie insertion, as we use that routinely, and 1 tube insertion in the mouth. So really expecting perfection. And our faculty in this role have achieved first attempt success in 91% of cases inpatient. And this is really impressive because, as with many hospitals, medical floors or other areas where cardiac arrest can happen, the space is cramped. It's not set up like our ED is. And so to be versatile enough to intubate with high success, I think is really important.
And these are both, this is, when we say medical emergency, cardiac arrest, emergent airway, and a non-arrest patient, all the whole gamut of anything emergently needed. Sudden hypoxemia in an intubated patient might prompt a medical emergency, anything like that. So 91% first attempt success in kind of all over environments. I think that just speaks to, the comfort level in the stabilization room. What is your approach? You get called up, you're working a shift, and you get called to a medical emergency, and you're on the inpatient floor. In the back room, in the very last hallway, all the way to the end, which is always typically happens, what are your when you enter the room, what is your kind of thought process? Because to you, this is an undifferentiated patient, right? That we have no idea on, even if they've been in the hospital for 2 months. This is the field of emergency medicine.
Yeah, when I respond to a code, there's a code team that is made up of inpatient physicians at our hospital, including a lot of physicians in training. And they're really responsible for understanding what's going on and what's the differential, what needs to be done to start ACLS or standard resuscitation measures. I can really take the backpack we use right up to the head of the bed and work on the airway. And so as I assess that airway initially, I care about what the patient's brain cares about, and that's oxygenation and ventilation. So I need to ventilate that patient if they're not breathing effectively. And so that should be done first. Non-invasive is a good approach with a bag valve mask. We use a two-person bag valve technique. So I'm getting the seal with the mask and asking a respiratory therapist or another physician to ventilate the patient with the bag. Because we carry supraglottic airways and King airways are stored on every crash cart in our hospital. Those are easily accessible. Sometimes respiratory therapy has even placed one and inflated it in a cardiac arrest situation before we arrive. But I think starting with a supraglottic ventilation if bag valve is challenging is the way to go. And that gives you time, and that's time to draw up medications if you need it, to get equipment out of this modular bag, and to get ready for your first intubation attempt. Yeah,
that's exactly that's a great point. Because I treat these, if just looking at cardiac arrest, I treat them like an out-of-hospital cardiac arrest, because that's essentially what it is. I'm going into a less familiar environment, and I've got a patient in cardiac arrest. And my first move generally is to place a supraglottic airway, because while intubation, we want them to leave the endotracheal tube in, it takes time. If to do it right and to do it properly, you're looking 2 to 4 minutes of prep depending on the patient. So I think putting in a King or an ILMA, inflating the cuff, getting good end tidal, confirming ventilating, now you get all the time in the world. And there's a lot of pre-hospital data to show that there's clinical equipoise between a supraglottic and a tracheal tube. Never been looked at in this environment, but I think for the first few minutes, that's the right move to do. I think for me, when I go up there too, and this is not in cardiac arrest, but this is a patient that needs an emergent airway, my first thought is, can I get this patient upstairs to the ICU? Because that, I think, is the most important thing, is because much bigger rooms, staff members that are familiar with intubation and crash intubations, and just working with our nursing supervisors and our patient flow folks, can I get this patient upstairs? Can I BiPAP them and pre-oxygenate them on the way up? I think that's the best move. Not possible.
Yeah, I think so too. And we've got partners in our ever enlarging ED group who are happy to intubate wherever that patient is. We got the skills and the equipment that we carry with us, so we could perform that procedure. But I agree with you. I think in cases where your assessment is this patient's not going to arrest in the next 5 minutes, let's get them to a critical care area where we can do the airway with some built-in safety and be ready for next steps where they're going to be anyway. So I think it's really important. It kind of mirrors what we do in our ED, in that we have a designated critical care room with 4 bays. We bring all patients that need advanced airway management or are at risk of needing it to that area. We don't bring the airway cart to them, right? And that lets us do it in a standardized fashion, same way every time, and supported by team members that are dedicated to that space. So same thing with inpatients. We should get them to the ICU, if at all possible, before cardiac arrest.
I think a lot of places too, for flexibility, they make these like the flex room, right? Well, we have 10 rooms, but any of them can turn into a stabilization room. Not optimal. not ideal, because it's not as fast or as easy to set something up to turn into a patient that I might need to intubate and suddenly do an open thoracostomy on to this to that. Having all the equipment located in one easy label place, I think, is really important.
Yeah.